Hello, I'm Dr Jack Milln and welcome to the first episode of PubMedicine. Now, the idea of this channel really is to condense topics in global healthcare into about 5 or 10 minute slots in a more digestible way, much as I would normally do in the pub. And the ideas come from a recent trip I did to the UK for a couple of weeks, and I was seeing and catching up with all my family and friends. And the first thing they asked me was, what about this Ebola outbreak? Which is a sensible thing to ask, because I'm a doctor and I work in Africa, and I used to work in Sierra Leone as well. And of course it's been in the media, so it's a sensible thing to ask. So I had this conversation about Ebola many times with people, and so I thought I would broadcast it in case anyone else was interested. So I'm going to set myself 5 minutes, and I'm probably going to go over. So Ebola virus, it's a viral hemorrhagic fever. That means it's a virus, so it's a chain of proteins, not a bacteria like a single-celled organism. And it causes a fever and a headache and the normal virus-like symptoms, and it's hemorrhagic as well. The last phase of the disease causes you to bleed from your eyes and your ears, and it's a horrible way to die, and I'll get on to why that happens later. The first thing I want to say is that Ebola virus is not designed to spread between humans. Okay, any infectious agent, virus, bacteria, or parasite, in order to replicate, it normally wants to keep the host, so in this case us, alive for as long as possible, so that it can spread the infection to other people. So when you get the virus of the common cold, you can still go to work and sneeze on your colleagues, and that virus can spread from person to person. Or with HIV, if it's not treated, you've got 10 or 15 years to then spread that virus to other people. And they're very successful viruses in spreading through a large population, whereas Ebola probably isn't, because it kills most of the people that it infects, and quite quickly. The natural host and the natural reservoir is monkeys and also bats, fruit bats. So it's when people come into contact with these, when they're eating bushmeat in the jungle, or they're going in and interacting with bats. I don't know how they interact with bats, but going into caves, and they get the virus, and then it's spread in the human population. So that's something that works to our advantage when trying to control an epidemic of Ebola, for example. So how do you get Ebola virus? The simple answer is bodily fluids, which means sweat and tears and diarrhea and vomit and blood. But what does that really mean? I mean, if I touch someone with Ebola who's sweating and it gets on my skin, do I get Ebola? Probably not, because the virus concentrations are very low in the sweat. But what it does mean is if I'm a family member nursing someone who's got Ebola virus, who's got profuse diarrhea and a lot of vomiting, then I'm certainly at risk of contracting the virus. If I'm a healthcare professional and I'm testing the blood of someone with Ebola, then again, I'm at risk of contracting the virus. And if our traditional funeral practices, like they are in a place like Sierra Leone, involve touching the body after they've passed on and keeping them in the house for a long time, family members are at risk of contracting the virus. So it's not really a 28 days later scenario where if you look at someone with Ebola, you catch it yourself, and it's not aerosol and it's not going to spread through. Obviously, in tightly packed slum areas of cities, there is a risk of this disease spreading quickly, but it's not as though if you brush up to someone with Ebola, you'll catch it. So what happens if you get the virus? If you come into contact and catch the virus, firstly, there's an incubation period, probably of 5 or 6 days, where you're asymptomatic, you don't have symptoms as the virus begins to replicate in the body. And then you begin to get the general virus flu-like symptoms. You get a headache, you start sweating, you get a sore throat, and then you may start having vomiting and diarrhea. As well. And it's at this point really that two things can happen. Either your body learns to deal with the infection and clears the virus, or you go into the last stage, the hemorrhagic, the bleeding phase of the disorder. Now, our blood's made up of red blood cells carrying oxygen, white blood cells for fighting infection, and then the rest of the blood, which has antibodies and clotting factors. We're constantly getting small cuts in our skin and mucous membranes, and our body makes small clots to plug these up. In this case, your clotting factors in your blood are used up. Clots form in your organs, which damage the organs, but you don't have any clotting product left to plug small gaps elsewhere, and so you start bleeding from the ears and the eyes and around the mouth as well. Now, this is a common actually endpoint of many other infections as well, and bleeding disorders where you don't have clotting products and you bleed. And the treatment for that is very difficult. Even in the West, in the best hospitals, you need to use clotting products, which are expensive and need to be kept frozen and refrigerated, and it's certainly not something which can be done in rural West Africa. The next thing is this mortality rate, which is being thrown around. 50 or to 80% is a range which is typically used in the newspapers. What does this actually mean? Does this mean 80% of people that come in contact with the virus die? It's probably not. What they're probably referring to is the case fatality rate. So this is the number of people who are seen as cases. They've either tested positive for the virus or they have signs which are very indicative of having a symptomatic form of the virus. It's the number of these cases which die. There's probably a large number of people who come in contact, get very mild symptoms or no symptoms and clear the virus themselves. So the percent in contact is probably much lower than this. This is the case fatality rate. Why is there such a range? Probably because people die of the virus for different things. Some of that hemorrhagic disorder that we talked about, but the middle ground, people that have diarrhea and vomiting, perhaps if they're cared for well with IV fluids, for example, they might survive. But if they're in a rural area, they may not get that supportive care and they would die. The next is genetics. Different populations will react differently to a virus. And the other thing is that there are different strains. So when people are talking about Ebola virus, there's 5 different strains which have been identified already. So I was recently in Bundabujo in Uganda, where they had an outbreak some years ago, and the case fatality rate was just 25%, because that strain of Ebola virus acts in a very different way and in a very different population. So why is it so hard to control? And my friends who are working on this in Sierra Leone will kill me for saying this, but actually on paper it's very easy to control. If someone with Ebola comes to the UK or the USA, then that virus will not spread in the population because they will be isolated and certain precautions and case tracing will go on. It's a very noisy disease. This is why it doesn't spread insidiously in a population, because people have very pronounced symptoms, and you know when an outbreak is happening, and so you can address it quite quickly. And because of this, and because it captures the public imagination, the world's attention is on this epidemic. For the number of people that have died in the epidemic, compared to how much of the world's attention has been focused on, it's probably the highest, certainly, of this decade. So there are things that might make you think that it's easy, but what about what makes it difficult? The first is that when we're dealing with something with Ebola, we're not just dealing with a virus. We're dealing with how a virus affects a certain population in a certain place. And that's the essence of tropical or developing world medicine, really, thinking about all the cultural and political things which go into the spread of a disease. Now, if you are a person living in rural West Africa, this is what you see. And people are rational beings, and they'll put 2 and 2 together. So they see a bunch of white people coming into their country, and they see them in spacesuits, coming into the countryside, and suddenly their family members are dying because they're bleeding through their eyes and their mouths. And any rational person would put 2 and 2 together and make the assumption that these people are killing their family members. So there's a lot of education and sensitization which needs to happen before the rumour mill starts going around and people start running away from the healthcare which is being focused in their areas. There was one story from the Children's Hospital in Freetown recently. They did a big vaccination campaign, vaccinated lots of children. 2 weeks later, Ebola came to the city, and the mothers, talking as they were cooking for the families, came to the assumption that it was because of the vaccines that people were getting Ebola. And I will defend them because there is some truth in the assumptions that they are making. The first Ebola outbreak in the 70s in Zaire, now DR Congo, they finally, once they had addressed the population and traced where the infection was spreading from, they traced the source of the infection back to a hospital which was run by missionary nuns. They were reusing needles when they were injecting pregnant and postnatal women with different vitamins to help them through childcare. And that was the source of the spread in the infection. Now, I'm not saying anyone's reusing needles now, and I'm not saying that any of the healthcare we're providing is causing it. But, those assumptions are based on things like that. The other thing which makes it difficult is the spread to healthcare professionals. There's no other disease which is more risky for a healthcare professional than Ebola, and so people are not wanting to take up their normal role in the healthcare response there. Is there a treatment for Ebola virus? I mean, firstly, viruses are typically very hard to treat because they hide inside of our cells compared to perhaps other bacteria or parasites which are on the outside and look very different to our bodies, so we can focus on them particularly. But viruses are very difficult. Is there a treatment? There's the supportive treatment that we talked about, and that's giving IV fluids from someone that might have the diarrhea and vomiting. That's the first thing which needs to be addressed and got right. And the second is the virus. Is there a treatment for the virus? Treatment it can be, or protection against a virus, it can be active or it can be passive. Active is when we give someone a bit of a virus way in advance, months in advance, and teach their body how to deal with it. That's a vaccine, so their body can actively fight the virus when it comes into contact. There isn't currently a vaccine ready for Ebola, but there have been related ones in the laboratory which are showing good results. There is a passive treatment which is available. This is the ZMapp, which has been in the media recently and given to the 2 Americans that have contracted the disease. This is when you take the serum or the watery part of someone else's blood who's had the virus and give it to someone so that can neutralise the virus in their body. And it's shown very good results in macaque monkeys where the experiments have been done. Why have we got these treatments? I mean, it costs $1 billion to take a drug from an idea to the shelf. Why would someone spend $1 billion making a drug which is only going to be used for 1,000 people perhaps every couple of years? There's no way a pharmaceutical company would do that. And so most of the research has been coming from the US Army and the anti-terrorism organisations, which are worried about these viruses as a bioterrorism threat. So the other viral hemorrhagic fever in Sierra Leone, that's Lassa fever. They have a big laboratory there working on the testing and the treatment of Lassa fever. You might say it's not for the West Africans, but it's in case the virus comes into contact with people in the USA. Does it matter? I don't know. How much of a problem is Ebola virus? I think it is important to put this into perspective. So since the beginning of the epidemic, there's been about 1,000 people that have died of Ebola virus in the last 6 months. I think that's probably an underestimation because I think there's other people that have died in rural areas that haven't been recorded. So perhaps it's double that. Perhaps it's 2,000 people in the last 6 months. Today, 6,000 people will die of malaria, mainly children, and 6,000 yesterday, and 6,000 tomorrow, and 6,000 the day after as well. So I think that puts the numbers into perspective a little bit. I don't want to say this is not an important outbreak, an epidemic of Ebola, and it requires all the attention that it's getting, but it's important to put it into perspective. HIV deaths, 2 million every year. 15,000 people die of HIV-related deaths in America each year, far more than dying of Ebola at the moment. What's the real cost of Ebola? Is it the number of people that are dying? I would argue there are other real costs as well, as all the borders have been closed, movement of people and food and trade have been restricted. And talking to people who are just coming back from Freetown now, food prices on the streets are going up. When I worked in Sierra Leone, I ran a malnutrition unit, so I know about the thousands of children that die of malnutrition in Sierra Leone every year, and very marginal increases in food prices are going to make that number rise even more and put even more children at risk of malnutrition related diseases like tuberculosis and malaria. So perhaps the numbers that are dying as a result of the Ebola epidemic are larger than the numbers we're seeing in the papers. The other thing is that, Sierra Leone's come out of a vicious civil war 13 years ago now, and only just are people getting our industries and tourism really having the confidence to go and invest in a place like Sierra Leone. Travellers are coming there for the first time, and industries getting going. And this is another black mark against Sierra Leone's name, which will put it back another few years again. The other thing is that many of the services still are supported and reliant on NGOs. And since the epidemic, a lot of those NGOs are pulling out, and they're pulling out their staff. These are NGOs that are working in things like water and sanitation. They might be capacity building in government sectors as well. And my friends that worked in those NGOs are now coming back to London against their own will, but the NGOs obviously feel a responsibility to them. So that'll put them back another few years in terms of that. So, it's not, I've put it in perspective perhaps against some of the bigger killers like malaria and HIV. So why is there such media hype about Ebola and there's not more media hype about those other diseases more often? I think firstly, it's an easy gig. That's the first thing I'd say. It captures the human imagination. And it does, and that's why everyone's been asking about it, because it has the feeling of these outbreak movies or sort of zombie killer movies. And as a story, it probably has a beginning where it started, a middle now where we're all very worried about it, and it'll probably have a happy ending. And that'll happen over a few months, which is perfect for a story in the newspapers and on the news. And I think the numbers are digestible. The other numbers I gave you, they're hard for us to really appreciate. But when you're talking about hundreds of people that have died, that's something that we can understand and something that we can relate to. It's a sort of tragedies versus statistics scenario. And is it in the media because 1,000 West Africans have died? I mean, it's probably not, because we know there's thousands in sub-Saharan dying of other things all of the times, and they're not in the media. I think someone more cynical than myself would probably say that it's in the media because there's a risk that someone whose life is worth more than the average West African is at risk. So that's healthcare professionals, and perhaps it's someone being at risk who's from the UK or from America, and that's what we're scared about. But of course, that's someone more cynical than me. So I think we're coming to the end. Further reading, I'll pop up a picture of a book here. This is Peter Pyatt. He's the director at the London School of Hygiene and Tropical Medicine. Spent most of his career with HIV/AIDS, but the beginning part of his career was spent in Zaire looking at that first outbreak of Ebola in the 70s. And they were the first people that isolated the virus. And the first third of the book is dedicated to that, and that's worth a read. And also go and see what my friends are doing, the King Sierra Leone partnership at the moment, and there's the website for you. It's an important outbreak. I think it's great that people are focusing on it and learning about healthcare in Africa. I would say from the inside it's quite hard because we're constantly trying to tell people about all the different issues in healthcare in Africa, and no one listens, and then one relatively, small outbreak takes all of the world's media attention for a couple of months, and everyone is absolved of thinking and having responsibility for healthcare in Africa for another year. I hope you enjoyed the video. Send me any feedback or any topics you want looked at in the future, and I hope to see you again.